In this presentation, I will talk about the mechanical ventilation. Ventilation is the process by which the lungs expand and take in air, then exhale it. A mechanical ventilator helps with this by pushing air into the lungs from an external device through a tube that is inserted into the patient's airway. The respiratory system or ventilatory system is a biological system consisting of specific organs and structures used for the process of respiration in the organism. Oxygen and carbon dioxide are exchanged by diffusion between the gaseous external environment and the blood. This exchange process occurs in the alveoli, air sacs in the lungs. B. Exhalation. As the diaphragm relaxes, it puts pressure on the lungs to expel the air. Exhalation is a passive process due to lung recoil. The spontaneous breathing. A. Inhalation. When the diaphragm contracts, the ribcage expands. This results in a larger intrathoracic volume and negative intrathoracic pressure (IPT) with respect to atmospheric pressure inside the thorax. As the pressure in the chest falls, air moves into the lungs due to pressure gradient. Air flows into the bronchial tree and through it to the alveoli. Inspiration is an active process requiring muscular effort. During spontaneous breathing, lowering the diaphragm and expanding the rib cage creates a decrease in alveolar pressure, negative pressure when compared to atmospheric pressure. It is this negative pressure that causes air to enter the lungs. Respiratory failure is the inability to perform adequately the fundamental functions of respiration to deliver oxygen to the blood and to eliminate carbon dioxide from it. Respiratory failure can come A. Abruptly. Acute respiratory failure when the underlying cause progresses rapidly. Slowly. Chronic respiratory failure when it is associated over months or even years. To solve the problem of respiratory arrest or respiratory failure, a mechanical ventilation has been proposed. It is used to improve the rate and depth of breathing during respiratory failure by generating and regulating the flow of gas into the lungs. For mechanical ventilation, the ventilator must fulfill three different tasks. 1. Oxygenation of the patient. 2. Partial or total assumption for respiratory work. 3. Monitoring of the device and patient. Two groups of ventilators exist. Short-term treatment using intensive care respirators to support patients following certain surgical procedures or assist patients with acute respiratory disorders. Long-term therapy used at home for chronic respiratory disorders. Invasive ventilation. A plastic tube inserted into the trachea. A tracheostomy is a surgical procedure to create an opening through the neck into the trachea. A tube is usually placed through this opening to provide an airway. This is done for long-term care of the airway. Endotracheal intubation is when a tube is placed via the mouth or through the nose to provide an airway for short-term protection of the airway. Non-invasive ventilation (NIV) refers to the administration of ventilatory support without using an invasive artificial airway, endotracheal tube or tracheostomy tube. Negative pressure ventilators. The flow of air to the lungs is created by generating a negative pressure around the patient's thoracic cage. The negative pressure moves the thoracic wall outward, expanding the intrathoracic volume and dropping the pressure inside the lungs. The pressure gradient between the atmosphere and the lungs causes the flow of atmospheric air into the lungs. The inspiratory and expiratory phases of the respiration are controlled by cycling the pressure inside the body chamber between a subatmospheric level inspiration and the atmospheric level exhalation. Flow of the breath out of the lungs during exhalation is caused by the recoil of thoracic muscles. First, design of negative pressure ventilators. Known as the iron lung. The metal cylinder completely engulfed the patient up to the neck. The neck is sealed with a rubber gasket so that the patient's face and airway are exposed to the room air. The patient is contained in a sealed chamber in which the pressure can be reduced, which resulted in expansion of the patient's chest. This change in chest geometry reduced the intrapulmonary pressure and allowed ambient air to flow into the patient's lungs. Pressure is then returned to atmospheric, allowing the lungs to expel some of their air. A pump controls airflow, periodically decrease and increase the air pressure within the chamber. Advantages of the negative pressure ventilators. More physiological. The ventilation was carried out without the installation of a tracheotomy or endotracheal probe. Non-invasive mechanical ventilatory techniques, and patients can talk and eat normally. Disadvantages. The negative pressure generated was applied to the chest as well as the abdominal wall, thus creating a venous blood pool in the abdomen and reducing cardiac output. Negative pressure ventilator is by necessity large, limit access to the patient for therapy, and leads to patient discomfort. Positive pressure ventilators work by increasing the patient's airway pressure greater than the atmospheric pressure through an endotracheal or tracheostomy tube. This causes the lungs to expand due to internal pressure and then to recoil naturally, expelling a portion of the air once the positive pressure is removed. During inspiration, the inspiratory flow delivery system creates a positive pressure in the tubes connected to the patient airway, called patient circuit, and the exhalation control system closes a valve at the outlet of the tubing to the atmosphere. When the ventilator switches to exhalation, the inspiratory flow delivery system stops the positive pressure and the exhalation system opens the valve to allow the patient's exhaled breath to flow to the atmosphere. The use of a positive pressure gradient in creating the flow allows treatment of patients with high lung resistance and low compliance. Mechanical ventilators. Transport ventilators. These ventilators are small and more rugged and can be powered via AC or DC power sources. Intensive care ventilators. These ventilators are larger and usually run on AC power. This style of ventilator often provides greater control of a wide variety of ventilation parameters. Many ICU ventilators also incorporate graphics to provide visual feedback of each breath. Neonatal ventilators. These are a specialized subset of ICU ventilators that are designed to deliver the smaller, more precise volumes and pressures required to ventilate these patients. Positive airway pressure ventilator. These ventilators are specifically designed for non-invasive ventilation. This includes ventilators for use at home for treatment of chronic conditions such as sleep apnea. General categories: the controller and the assister. In the controller, the machine controls the volume and the respiratory rate. Patient does not participate in ventilation. The assister, the machine detects the patient's attempt at ventilation and augments it mechanically. Thus, it assists rather than controls the patient in ventilation. Definitions: tidal volume (Vt) is the volume of air inspired or expired with each normal breath. Residual volume (Rv), the volume of air remaining in the lungs after a maximal exhalation. Airway resistance, the resistance of the respiratory tract to airflow during inspiration and expiration. Pulmonary compliance, lung compliance, is defined as the change in lung volume per unit change in transmural pressure gradient, that is, between the alveolus and pleural space. Positive and expiratory pressure, or PEEP, is the pressure in the lungs that exists at the end of expiration. Fraction of inspired oxygen, FiO2, the fraction of inspired oxygen delivered to the patient by the ventilator. Apnea, temporary absence of breathing. And finally, sensitivity, used to determine the patient's effort to initiate an assisted breath inspiration. Definitions: inspiratory time Ti, expiratory time Te. The total cycle time TCT equals inspiratory time plus expiratory time. Respiratory rate (RR) is the number of breaths taken within a set amount of time. Inspiratory to expiratory time ratio, it refers to the ratio of the inspiratory time to the expiratory time during the breathing cycle. The ventilator components are power supply, gas mixer, pressure sensor, flow sensor, pressure flow generator, breathing system, gas humidifier, heater assembly, thermistor, valves, operating and display unit, alarm system, and patient monitoring. The ventilator components. Alarm system. Ventilator alarms must never be ignored or disarmed. The alarm system ensures that the ventilation parameters set in the operating and display unit are actually applied. It also issues audible and visual alarms to alert staff to critical changes in the patient's condition or technical malfunctions. Ventilator components. Gas mixer. The gas mixer allows the user to vary the oxygen concentration of the inspiratory gas between 21% and 100% by volume. Pressure flow generator. The pressure or flow generator is responsible for delivering the mixed gas prepared by the gas mixer according to the ventilation parameters set in the operating unit. A flow generator is a controlled valve whose output provides a defined gas flow. The output pressure is not specified. A pressure generator behaves similarly to a compressor whose output provides a defined pressure with an unspecified gas flow. The air and oxygen flow sensors generate signals to help the microprocessor control the valves to deliver the desired inspiratory air and oxygen flows. The airway pressure sensor generates the feedback signal necessary for maintaining the desired positive and expiratory pressure, or PEEP. Breathing system, an inspiratory and an expiratory hose, dual hose circuit. The expiratory valve is closed during the inspiratory phase. After the inspiratory phase, the patient exhales when the expiratory valve is opened. Gas humidifier. To warm and humidify the inspiratory gas. Expiratory valve. 1. If the valve is not opened completely during expiration, a positive and expiratory pressure or PEEP is created in the lungs. 2. Controls the valve during the inspiratory phase. It can compensate for undesirable pressure rises in the breathing system caused. Operating and display unit. Touch screens designed to display pressure and flow curves as well as multiple menus for setting different ventilation modes, adjusting alarm limits or measured value overviews. Patient monitoring. To monitor the patient's vital functions. This includes, for example, electrocardiogram or EKG, blood pressure, non-invasive or invasive, oxygen saturation, and often also the measurement of the carbon dioxide concentration in the breathing gas. Breath sequence. Two clinically different breath types can be provided during mechanical ventilation: mandatory controlled and spontaneous breaths. A spontaneous breath is both initiated and terminated by the patient. If the ventilator determines either the beginning and or the end of the breath, it is mandatory. The three types of breath sequences during mechanical ventilation are continuous mandatory ventilation (CMV), intermittent mandatory ventilation (IMV), and continuous spontaneous ventilation (CSV). The trigger variable initiates inspiration. If time triggered, the ventilator initiates inspiration at a clinician-determined interval. For example, the ventilator will initiate inspiration every 3 seconds if the rate is set at 20 per minute. Initiation of inspiration can also be triggered by the patient. Patient triggering can be recognized by the ventilator as a pressure signal, a flow signal, or a signal from diaphragmatic activity. Pressure triggering occurs when patient effort causes a drop in airway pressure to a clinician preset level. Sensitivity setting. Flow triggering occurs when the patient's inspiratory flow reaches a clinician preset level. With neutrally adjusted ventilatory assist, the breath is triggered by the electrical activity of the diaphragm. The limit variable is the pressure, volume, or flow that cannot be exceeded during the inspiratory phase. Inspiration is not necessarily terminated when the limit variable is reached. Pressure-controlled ventilation is pressure limited because the pressure limit is reached before inspiration ends. For some ventilators, the inspiratory flow, inspiratory time, and tidal volume are set separately. In this case, the ventilator is volume limited because tidal volume is delivered before inspiration ends. The ventilators can be time cycled, volume cycled, or pressure cycled. Time cycled, the negative pressure is applied to the body for a given period of time and then released for another given period of time before the process is repeated. In the volume-controlled ventilator, the progression of the cycles of the ventilator is controlled by the volume of air administered to the patient. Thus, if a machine is set to cycle on a given volume, it doesn't cycle until that volume of air has been administered to the patient. It also has a pressure override valve so that if while the machine is in the process of administering the set volume, the pressure exceeds a predetermined maximal value, the ventilator will cycle whether or not the appropriate volume has been administered. In the pressure-cycled ventilator, air is administered to the patient until the pressure reaches a predetermined limit, at which time the ventilator switches to its expiratory portion of the cycle and the process is repeated. The cycle variable 1. Time cycled mode. The duration of the inspiratory and expiratory phase and thus also the switchover time is defined by user adjustable time parameters. Controlled mandatory ventilation modes are often implanted with this control type as it enables patient ventilation with a defined ventilation ratio, inspiratory to expiratory time. Volume cycled mode. The switch over from inspiration to expiration occurs, in this case, after the delivery of a ventilator volume or tidal volume to be defined by the user. The next inspiration takes place after a time phase has elapsed, volume time cycled mode, or by a patient activity. Flow cycled mode. This control is primarily used for supporting ventilation modes and initiates the expiratory phase when the gas flow decreases to a defined value, for example 25% of inspiratory peak flow. The start of inspiration is mostly initiated by a patient activity and on reaching a trigger criterion. 2. Pressure cycled mode. The switch over from inspiratory to expiratory takes place when an adjustable ventilation pressure has been reached. Inspiration takes place after a time phase has elapsed, pressure time cycled mode, or by a patient activity and on reaching a trigger criterion. Pressure cycled mode is mainly used with impermissibly high pressure rises in connection with an audible alarm as a safety element. The baseline variable is what is controlled during the expiratory phase. Most often, the baseline variable controlled is pressure. The end expiratory pressure may be set to 0 or Zbib, or a positive pressure may be created at end expiration (PEEP) by the closure of the expiratory valve before the lung has quite emptied.